Welcome, everyone, to our fifth Healthcare Data Matters webinar, where healthcare leaders and innovators join in conversation to set a new standard of patient-centered and data-driven care. Today's topic discusses saving baby brains with sedation management analytics and leveraging visual analytics for COVID and beyond. And I assure you, these are both very fascinating topics. So we gave ourselves 45 minutes on the time frame today, beyond our normal 30 minutes. But before we get to our guest, Dr. Achuff, let's do a little housekeeping if we could. I am Bruce Hall, and I'm your host for this series. It's my privilege to host both the webinar and the podcast version of this series. I'm looking out my window and seeing 15 inches of snow here in Massachusetts. And if you don't have a UPS because we've had a power outage, I strongly advise you to get one for your PC. That's the reason I'm still with you here today. So good thing. And let's start by covering a few disclosures if we could. First off, funding for the Healthcare Data Matters Forum is supported in part by Medical Informatics Corp. And Intel. Presenters' opinions and viewpoints are their own, and we do not pay speakers or offer any exchange for product endorsements. You can see other disclosures on this slide. Now it's my extreme pleasure to introduce our guest today, Dr. Barbara Jo Achuff. Dr. Achuff is an assistant professor of pediatrics in the Department of Pediatrics Cardiac Critical Care at Baylor College and practices at Texas Children's Hospital. As we said earlier, Dr. Achuff's topic is saving baby brains with sedation management analytics and leveraging visual analytics for COVID and beyond. Dr. Achuff will be discussing how she and her team developed an expanding, daily refreshed platform with interactive dashboards, including all medications administered to CICU patients, and how they leverage that data for quality improvement and excellent care at the bedside for the most fragile patients in the pediatric CICU. She will also talk about how the same visual analytics dashboard and integrated data from sickbay was leveraged to support virtual rounding and remote monitoring to enable better virtual collaboration among providers in this challenging time of COVID. We should note that all patient names and related information are fictional and for demonstration purposes only. How are you doing today, Dr. Achuff? You might want to take yourself off mute there, Dr. Achuff.
There we go. Excellent, Bruce. Sorry. I'm feeling very honored actually to be able to speak with you today.
Well, and having seen your material, I'm so much looking forward to this, and thank you so much for being with us. Let's go a little bit through our format today. We'll start by, I'll ask you some questions to give you a chance to present your work to our audience. And during our talk, audience members can ask questions they may have by typing them into the chat tab as shown on this slide. So just go to the chat tab and enter your questions, and we'll get to as many of those as we can at the end of this session. Sound good? All right, let's get right into it. Let's begin with a little bit about where you work. Tell us about your practice, the patients you care for, and the primary problems they are facing, please.
Well, I'm speaking to you today on a very sunny day in Houston. Actually, today looks just like this one picture. So I apologize to all of you up in the Northeast who are under a lot of white stuff. I don't miss it. But here, I work at Texas Children's Hospital in Houston. It's one of the largest and most comprehensive specialty pediatric hospitals in the country. And specifically, our heart center has been named #1 year after year. The building there in the center is our Legacy Tower. It opened in September 2018 with 4 floors of pediatric intensive care units and 4 floors of cardiac intensive care and additional floors for progressive cardiac care.
Well, you think of cardiac care as a specialty. Why do we need specifically dedicated pediatric cardiac care?
Well, Bruce, did you know that 1 in 120 babies every year, or 40,000 babies, are born in the US with a heart defect? Amazing. And many of those babies need open heart surgery before their first birthday. In fact, heart defects remain the leading cause of birth defect-associated infant death globally. And at TCH, we can perform even more than 1,000 surgeries a year. Many families then will find themselves in a room just like this one. The cardiac ICU can be a very complex place, and sometimes compared to an airplane cockpit, where everyone's working together for a safe landing and recovery after heart surgery. You can see the baby here is lost in the middle of all of that equipment.
Daunting.
You know, toward that goal, we use many, many medications to control pain and to offer quiet sedation, reducing fear while life-saving medications whistle and hum and devices stay securely in place. The next slide will summarize that. But with those terrific intentions of pain relief and anxiety, everything comes with side effects and overlapping symptoms. It complicates the sedation management at the bedside because really every medication choice and change that we mean for good comes with a price.
So we must sedate these babies to help them through what they're going through. Can you help us understand a little better the impact of sedation, particularly on baby brain development?
So in the end of 2016, the US Food and Drug Administration actually raised an alarm. They came out with a statement that children exposed to lengthy or repeated doses of anesthesia and sedation medications, especially those under age 3, that we may actually be causing harm to the developing brain. A very large and well-orchestrated study that was reported out of the Mayo Clinic in July of 2018 actually corroborated those findings and agreed with those conclusions, actually reporting that infants with multiple exposures to anesthesia and sedation medications were at risk for and had parental reports of childhood learning disabilities, ADHD, difficulties with executive functionings like packing a backpack, and even behavioral disorders. So the excellent and masterful surgical correction of a heart defect, met even with meticulous management of vital signs and physiology, still needs pain and sedation practice to move forward and offer excellent progress of care through the ICU safely.
So we must have some strategies to help avoid oversedation. Can you tell us about those existing strategies? And obviously, they're not as effective as they need to be. Can you tell us what's prevented those strategies from being implemented?
Well, the solution is known. It's just very hard to implement. And many institutions like my own have had multidisciplinary educational programs and lectures, web-based programs teaching about sedation and the harmful effects it may have on our babies, or how to manage it with the most validated sedation scoring. And some even have developed protocols and pathways for sedation management, as we did. This slide is actually not meant to be read, obviously, but this is our bundle that we produced that was age and weight-based, giving guidelines for the initiation and the maintenance of sedation and pain medications, the weaning of those medications, how to deal with some of the effects like delirium. But these bundles actually really weren't enough. And compliance with the guidelines was, even with the greatest attention, it wasn't really sustainable. We had to do something different. We had to have a daily review of the data rather than just look at our historical data and how we made an effect with our guidelines. We needed to have a daily effect and be able to adapt. So here at Texas Children's really came up with a more customized plan using the patient's own data. By taking the lists and list of documentations in the EMR and the electronic medical record, normalizing it with analytics, and then visualizing it with usable, efficient graphics pushed to the providers at the bedside, they would then be able to have data-driven decision-making and wisdom-guided practice at the bedside for each patient because, as we know, each child is unique and has unique needs, even from day to day. So, Bruce, let me give you a quick tour of this tool. And I do want to apologize because it's literally a 2-minute tour. If you want to hold the video for 1 second. I'd be happy to share this with anyone afterwards for a more thorough review. We're just really going to sprint through it really quickly. And I will remind everyone that the names and even the dates have all been changed for our privacy of our patients, just for demonstration. So if you want to start the video, this is the floor plan of the 17th floor of the Legacy Tower. Each patient is in a bed there, room 1 through 24. And if we drill down, each patient's data is behind that door. This is an individual profile with all the drugs that this patient has seen by drug class over time. As you can see, there's 3 weeks here shown up to the current day. This box actually tells you how many extra doses of medications the baby's gotten, yellow during day shift and blue during night shift. It gives some recommendations on how to maybe capture that baby's sedation a little bit better. Also does complex calculations of cumulative doses or total dose exposure for opioids there and morphine milligram equivalents by day and by hospitalization, and also for the class of benzodiazepines here by day and by hospitalization, which can bring insight to the team for that particular patient. Customizing specifics and a fluid treatment plan. I'll show you another example. Now, this is from the 18th floor of Legacy Tower, where a lot of our newborn cardiac patients are cared for. And if we drill down into this patient's individual profile, again, by drug class, all the medications the patient has seen over time, you can see that there's not getting a lot of extra doses. So we've really captured this baby with a great plan for sedation and pain management. This dashboard is very important to us in that it shows the patients that are getting more than 4 medications simultaneously at the same time in order for their sedation practice. That causes a lot of complications with delirium, prolonged ICU stay, like I said, overlapping symptoms. So we're trying to then customize those particular patients requiring 4 or more agents more specifically so that we can reduce the number of medications they see all at the same time. So this dashboard is reviewed every day with the team such that we can change and adapt to the patient's needs. We set a goal, as you can see, to decrease the number of patients on 4 or more agents, which that graph is showing you, down to 1 in 5 or about 20% is what we would expect at any day. So we've had a great success in decreasing the number of patients who are receiving more than 4 agents. But using those individual profiles, you can see that one size doesn't fit all. And actually, even day to day, a patient's needs can change. So by reviewing the patient data daily, each day, we can make a customized plan for each and every patient. So the creation and careful review, we can adapt, and we can adapt quickly.
So amazing to see this animation in real time. And this is a web browser interface, right? You can access this from anywhere, right?
Mm-hmm. Yep.
Yeah.
Even from our rovers in the hallway.
Wow, incredible. So you don't need to be by the bedside. You don't have to even be in the hospital. You can access it from anywhere where you have security, right?
Yes.
Yeah, fascinating. Just seeing the different graphs of what's going on in real time is fascinating and certainly would help on the spot with management. Do you have any results that you can share with us? Any impact? How have you seen improvements in any outcomes?
Yeah, so this shows that we've had a great reduction in the exposure to opioids. They're shown in blue over time. This is the number of rescue doses in the line graph, and the histogram is showing actually the average total dose exposure per patient. So you can see for opioids in blue, it's diminishing over time. And through 2020, it's also continued to decrease. And for our benzodiazepines shown in the orange here, we also have had a pretty significant drop, especially in total dose exposure. And that's even true for our smallest or youngest babies and those ones that we heed the warning from the FDA communication and the other literature that has come out. So the benzo sparing practice that we have provided has been very important. The next slide actually summarizes a few things. So not only the benzodiazepine exposure has decreased nearly 30%, and our patients that are receiving those 4 or more agents that cause overlapping symptoms and many complications, we've been able to decrease the number of patients by 50%. And then by really careful and adding meticulous management and weaning strategies to come off medications, even for our most fragile single ventricle, 1 ventricle patients, we've been able to decrease our opioid exposure really significantly.
90%, boy, it must be incredibly rewarding to know that you are directly impacting these babies' brain development. This is just incredible to watch. Shifting gears a little bit, Dr. Achuff, I understand the same interface that we just saw, that web-based interface, was being leveraged to help you manage COVID, right? You have a kind of a virtual interface that you can do virtual rounds, right? Can you tell us about that?
Yeah, so as all of the hospitals and the whole country then was challenged with the introduction of this novel SARS-CoV-2 and the global pandemic from COVID, we needed to be agile and we needed to act quickly on our feet. Not only, really being able to care for our healthcare teams, but pivoting to keep our healthcare teams safe, but still providing excellent care for our patients and our families at the bedside. So a big part of that, right, was creating new isolation units. We ended up having 5 across 2 campuses and 3 buildings. We had eager volunteers that then became obligate workforce. We've had many more patients than the 400 listed here that have received care for us, including adult patients shared among Texas Medical Center in our institution. And now, of course, we have an established track record, but we needed to really retool what we already had. And in order that gave us the agility to move quickly. So the next slide is actually, you'll recognize as the floor plan of the 17th floor, the Legacy Tower, the room 1 there and all the way to room 24. And the colors here, you can start the video, thank you. The colors here actually show green being tested and negative, the yellow being that they were tested in the past. And if they were positive tests, patients who had positive COVID tests, they would come up bright orange. This gives you a blink of an eye situational awareness about your patient's testing status and where our positive patients are coming up. So then what's most important is if you drill down, the data lives behind the patient, you're going to see the actual live monitor at the bedside. The GE monitor data is coming up straight from the GeoMap. We can review the data immediately without being at bedside, which changed our practice because a lot of our surgical patients, we review in big crowds at the bedside. We look at the monitors and the data, but now we're able to do it actually away from the bedside, protecting our healthcare workers, but also not having to all gear up with PPE to come into the room or to review the data. So we're jumping to another patient. You can see immediately comes up with the live GE feed. And so we can then review the patient's vital signs and the immediate current status of the patient and make efficient data-driven decision-making with our surgeons, with our ancillary services, with our consultants who may not be in the room, may not be in the floor, or may not actually be even in the same building, but can give us advice and allow us to have efficient and safe practices.
Wait, oh, is there more to this? I'm sorry.
No, I think we're just showing you that the PICU
Okay.
is also included, and so our PICU floor plan is also included. So our pediatric, not only our cardiac patients benefited from this, but all of our patients from other units as well. And so by creating new floor plans, even including our PICU, we were able then to have situational awareness for them. And as our patients moved from unit to unit, in isolation or non-isolation, we were able to continue to use the live sickbay feed.
Boy, really fascinating. And you wonder, kind of like the Zoom meeting we're having now and remote meetings, and how much of this will survive and be a valuable tool after the pandemic leaves us, right? How much of this will you continue to use and just be more efficient?
Well, I think it also adds a lot more collective learning and also a lot of shared knowledge and intelligence. So not only, can I have how many people at the bedside? Perhaps on a crowded day before COVID happened, we'd have 12 providers at the bedside, including surgeons and learners. But now this morning at 6:15, I can tell you there were 42 people on our meeting looking at the data all together. That is not only collective learning, but also an intelligence that brings a new level of care to our patients. So I am really thinking that this will be utilized after COVID for sure, for that very reason.
Wow, that sounds amazing. As if you haven't done enough, I understand you have some future plans coming up. So what are you doing to expand both the sedation work and the virtual rounding beyond COVID, and what other research work are you working on?
Yeah, so I can see, and I can tell you that even on the drawing boards behind me, that we're repurposing these geomaps for lots of different uses and different cohorts of patients. So our patients on mechanical support have their own dashboard that has embedded laboratory values, and we can follow anticoagulation values and labs like that. And as we gain more agility, like I said, with this tool, the curiosity, it just continues to rise, and we are finding many more uses for shared data and geomapping and dashboarding as my colleagues come up with questions. Actually, some of the data, it shows us the questions we didn't even know we had. The vaccine development that is happening, I can be happy to tell you that we've already deployed many thousands of vaccines in our institution and through the Texas Medical Center. And so that's good news. We right now are not following the vaccinations by dashboard, but it is another thing that we probably could do. So, and then the next slide will show you that we've used the high fidelity sickbay data. So those GE monitors, every heartbeat, every blood pressure, every breath is actually recorded data. We can go back historically and look at, and then ask questions to it as well. So not only to review events that happen in the cardiac ICU, but to review the treatments that we're using on our patients to see how it changes their physiologic data. So there's a lot of research that's coming out and being published out of those curiosities. How do different medications affect our hemodynamics in the ICU? So in sickbay data, the granular high fidelity physiologic data is being used in our ICU as well. And that now we have a weekly meeting in order to address some of those curiosity questions and get some research out. So that's also another very exciting part of how we utilize sickbay high fidelity data. So as you can see, yeah, we're really moving forward through, and the next slide will kind of just shows that everything that, as we become more versatile with today's analytics and the insights that we get from them really do make a difference in my patients' outcomes. And that's what's most exciting, is that we are bringing these analytics directly to the bedside for better data-driven decision making. And I really do believe that and have seen that we've had incredible differences in outcomes.
Virtual care, data-driven medicine results in parents that have to be eternally grateful for the work that you are doing. And it's just so fascinating to watch. And what a wonderful presentation you've given us today. And I know that this topic generates a lot of questions. So if you don't mind, if you can hang around, we'd like to introduce Raj Patel, who's MIC's VP of Data Science, and he's going to manage the Q&A for us. Raj, are you there?
Hi, Bruce. Can you hear me?
Very well. How you doing, Raj?
Doing all right. Doing all right. You holding up?
Yeah, take it away.
Okay. Yeah, so as it says on the slide, please click on the Q&A button and type your question in, and I will read them off so that Dr. Achuff can answer them. So a question came through, and this is specifically, for the dashboards that you were showing. Who wrote that software, and what underlying EMR are you using?
So we are an Epic house at Texas Children's Hospital, so that's an easy answer. And we are utilizing actually Tableau for our graphic representations in only really departmental use right now in the cardiac intensive care unit. We found that excuse me, it allows us to move from work that was imagined. So we thought we were doing just fine with the sedation practice. Even after implementation of those protocols, we thought everything was fine, the work as imagined, to then actually work as known. So when you do put the data in front of everyone, it changes. So the Tableau has really been helpful with our visualization. So just as that one slide showed, we take the EMR data out of Epic, we actually put it through sickbay and do some analytics on it, normalizing it from morphine milligram equivalents and diazepam equivalents, such that we can then visualize it on Tableau and push it out to the user, the provider at the bedside. Hopefully that answers your question.
It does, and there was a follow-up that somebody came through, just a bit of nuance. And correct me if I'm wrong, the visualizations of the floor is a Tableau visualization. The data behind each room is a sickbay visualization.
Yes, so Yep, the individual profile was developed actually and created through many iterations. That dashboard is sickbay medication data that then is put on the individual profile and updated very regularly and then reviewed every day. The COVID GE monitors is also sickbay data, the high fidelity physiologic data coming from the GE monitors. So we have the ability to take the medication data from sickbay and visualize it in our needs that way. And we have the ability to take the high fidelity data, what we did in the COVID dashboards, and visualize it that way. So same tool, retooled for a different use. But
Yeah.
so those graphics, the individual profile was built actually by a couple of us.
Very cool. More follow-ups. What is the frequency of the vital signs data which is displayed?
Okay, so the vital sign data, actually, as soon as you press the button on the dashboard, it's immediate, like exactly what's coming up, as if you were standing at the bedside looking up at the screen. So that is, as soon as you press that, and as soon as you go off to a new patient, it'll bring that data up immediately from that patient's monitor, as if you were standing at the bedside. So it's not delayed, maybe by what, Raj, 0.5 milliseconds, something?
Yeah, I mean, the sickbay data it's live, right? Near real time is the idea.
Yeah.
Okay, a question came through asking about a bit more of your research. Do you happen to have, well, first it says fantastic presentation. I think we're all in agreement about that. Is there data comparing reduction of sedation analgesia dosing with other CNS outcomes, imaging, and so on?
Yeah, excellent question, actually, because that's what I have probably in that pile right there. Is we have a clinic for neurodevelopmental outcomes that all of our cardiac patients attend at regular intervals after their heart surgery, whether they've had the most simplest of heart surgeries or even the most complex. All of our heart patients are seen in a follow-up clinic, and we are able then to do psychological testing or behavioral testing or neurodevelopmental testing in those clinics. And now we have, since we've been able to collect data and all of our total dose exposures for each patient, for each hospitalization, we can then compare it back to their testing. So we have historical data before we had this data, the total doses calculated. And what we'll do is we'll compare our historical controls against each other and find out if those patients who've had the higher doses actually have affected their own physiologic testing. So that is actually in the works, and I'm hoping to get that published in the next few months.
Well, some more research ideas are coming at you. Have you been able to track impact on incidence of ICU delirium along with this work?
So that's a really hot button, delirium. I don't think you can pick up any kind of critical care literature right now and not find something about delirium, because it not only complicates our care and our medication management, but it keeps kids in the ICU for longer. And so the specific metric of being on more medications that cause more delirium. So when patients have symptoms, we just add more medications. As we're finding out, if we undo and untie and untangle some of those medication treatments, we're finding less delirium. So as that graph went down on the number of patients on more than 4 medications goes down, it's almost identical, the prevalence of delirium in our ICU. We also have recently incorporated another delirium pathway such that we have raised the awareness of delirium, offered more scheduled kind of time schedules for the patients, like calendars for this during the day, and that's been very helpful. But I truly believe untangling the sedation management has been a big help in for our delirium in patients.
All right. Well, we're close to time for Q&A. So if you do have any other questions, please send them our way and we'll get them to Dr. Achuff and make sure they're answered. But for now, I think that's going to be it. Bruce, back to you.
And like I said, Raj, if I could just add that I'd be happy to share any of these tools with anyone. The success that we've had, I'd really like to share that success with other places as well. Just contact me. I'd be happy to walk through the tools with you at a slower pace.
Wonderful.
Well, or maybe in real time and not actual pre-recorded videos, maybe something like that.
True.
Let me add my thanks, Dr. Achuff, for sharing your wonderful work with us. Thank you so much.
Thank you.
To the audience, folks, will make Dr. Achuff's presentation, a replay of this webinar, and an audio podcast version available on healthcaredatamatters.com. While you're there, you can also check out our previous webinars and join the conversation on our associated social media channels. You'll be receiving a short survey after today's session, and we'll also be in touch with information on our next Healthcare Data Matters webinar coming up in March. Thanks again for joining us today. Here at Healthcare Data Matters, we are grateful to have the opportunity to advance a new standard of patient-centered and data-driven care. Take care and stay safe, everyone.